Hello, everyone. I feel deeply honored to be part of the 24th Provolent Congress of Pathology and to present a diagnostic approach to evaluating testicular biopsies for male infertility. Male infertility is not an uncommon problem in Western society. Approximately 15% of couples are experiencing difficulties with intended conception. A male factor is solely responsible for about 20% of these couples, and the contributory in another 30 to 40%. Male infertility can be due to a variety of conditions. These causes can be easily divided into three major categories: pre-testicular, testicular, and post-testicular. Pre-testicular defined as actual gonadal endocrine disorders, such as those originating in the hypothalamus, pituitary, or adrenals. These have an adverse effect on the spermatogenesis through aberrant hormones stimulation or suppression. Testicular may be congenital or occur secondary to environmental insults or diseases. And the post-testicular, which consists primarily of obstructions of the ducts. Due to these various causes of male infertility, a full evaluation is needed, and shown here. It's quite a busy information here. This is the male infertility algorithm recommended by 2020 American Urological Association. Includes comprehensive history and physical exam, at least 2 semen analyses, endocrine testing, and genetic studies. Testicular biopsy is generally reserved for men with azoospermia or absence of sperm from the ejaculate. It plays a pivotal role in differentiating azoospermia due to ductal obstruction from ablative testicular pathology. In order to interpret testicular biopsies, the pathologist must be able to recognize the individual germ cell types, which proceeds through spermatogenesis in an orderly fashion. Let's also refresh our memory here. The active component of each testis consists of several hundreds of seminiferous tubules, and shown here. At the intermediate power view, we all can see these spermatids adjacent to the lumen. In each tubules, all stages of the differentiation are present simultaneously. The process actually starts with the spermatogonium, which resides next to the basal lamina of the tubules, relatively small cells with pale staining nuclear chromatin. At the sexual maturity, portion of the spermatogonium divides and differentiates through mitotic cycles and give rise to the primary spermatocytes, which quickly undergoes its first meiotic division. This stage requires approximately 3 weeks. That numerous primary spermatocytes are present in the cross sections of the tubules in a typical biopsy. The primary spermatocytes are the largest germ cells in the tubules with prominent chromatin calling. After meiotic division, smaller secondary spermatocytes are performed, which is occasionally visible, and typically far fewer than primary spermatocytes due to the short time interval of this stage. They quickly underwent a second meiotic division, resulting in spermatis. Spermatis is much smaller than other sperm cell types and characterized by their elongated, dark, condensed chromatin and juxtaluminal location. Cytotic cells are other intratubular pyramidal cells with their base adhesion to the tubule's basal lamina contain a prominent centrally located nucleoli and fine granular chromatin in distinct cell border enveloping the spermatogenic cells. The current recommendations for the reporting of a testicular biopsy include seminiferous tubules hyalinization, as shown here. All tubules are hyalinized and acellular. Cytotic cell only syndrome and hyperspermatogenesis, which I will illustrate in the following slides, and the maturation arrest, which the picture I borrowed from webpathology.com. Here we can see numerous spermatogonia adjoining the basal lamina, few spermatocytes, and no mature spermatis. There are also, we can also see the cytotic cells as well, morphologically distinct from these sperm cells. With this, let's go over several cases. A 31-year-old male with his 28-year-old wife attempted to conceive for over 1 year for the first time without success. 2 semen analyses revealed azoospermia. He had a limited male endocrine profile, showed elevated FSH levels, clearly indicating an abnormality in spermatogenesis. Others hormones are within the normal range. Bilateral testicular biopsies were performed with similar microscopic findings. Here we see numerous seminiferous tubules with reduced diameter. At this lower power view, I also assess the specimen adequacy. 9 to 20 seminiferous tubules with intervening septa are considered adequate. It's about the size of grain of rice, 3 millimeter in any one dimension. Also, another impression from this lower power view, you can see this cellularity actually decreased in all tubules. In the luminal area, we didn't see any spermatis at all, and some tubules showing this second basal memory appearance as well. At the higher power view, we see this kind of similar impression with the reduced cellularity without any spermatis, and there are some lytic cells in the interstitial, in the clusters. And then we only see these cells with features of cytotic cells, as we mentioned before, this fine granule cytoplasm, prominent nuclei centrally located. And then we didn't see any convincing other sperm cell types, including the spermatogonial and the primary or secondary spermatocytes at all. At even higher power view kind of confirmed our impression at the low power view. Only Sertoli cell present, showing this wide wind-swept appearance without any spur cell types. So this Sertoli cell only pure germ cell aplasia homogeneous pattern is diagnosed based on the morphologic findings in bilateral seminiferous tubules. Also, I always mention the seminiferous tubules are present and adequate for evaluation, kind of as a specimen adequacy. Talk a little bit about the Sertoli cell only syndrome. By definition, is a complete absence of germ cells as we saw in the cases in testicular tissues, and always results in male infertility. Although the etiologies do remain unknown, it is associated with the numbers of conditions. Karyotype abnormalities occurring in 20% of cases, especially Klinefelter syndrome, the most common abnormality seen in the Caucasian endospermic men with Sertoli cell only syndrome. The patients with a normal karyotype, 9% of them showed azoospermia factor deletions. Another association of these conditions include adult cryptococci testis, post-radiation of chemotherapy, estrogen and anti-androgenic therapy, among others. So our patient underwent a bilateral microsurgical testicular sperm extraction. Sperm was successfully retrieved and preserved. The couples was encouraged to proceed with intra-fertilization. So talk about a little bit about this procedure, microsurgical testicular sperm extraction. It is a procedure that takes sperm directly from the testicular tissue. It is also golden standard method for surgical sperm retrieval. The seminiferous tubules are surgically exposed during the procedure, and then the surgeon gonna systemically examine for dilated opaque tubules, because these enlarged dilated tubules may contain active spermatogenesis, and non-enlarged are most likely to contain no active spermatogenesis. Like our case, although in bilateral testicular biopsies, the patients show the only Sertoli cell only syndrome, but the sperm still successfully retrieved. So once these dilated tubules are identified, the entire length of the tubules is removed for sperm retrieval. This procedure significantly improves sperm retrieval rates in patients like our patients. Another case is a 26-year-old male attempted to conceive with his 23-year-old wife, at a very young age, among 20 years. for 14 months without success. Similarly, sperm analysis also performed, revealed azoospermia. His male endocrine profile is all including testosterone, LH, FSH, estridium, sex hormone binding globulins were all in within the normal range. A section of his testicular biopsy kind of show the relatively stellar findings with some mixed patterns. Here on the right tubules, this side tubules, we can see kind of a numerous spermatids in the lumen. Here, kind of less in these tubules, but we can see this spermatogonia and the basal lamina. There are also spermatocytoid cells with other stage of spermatocytes, most just the primary spermatocytes. And again, in the lumen, there's a were typical features showing these spermatids as well. Same thing, similar findings in other tubules as well. Although the all stage of sperm cells present, the numbers actually showing the overall reduction. So this brings up the questions how we quantify the spermatogenesis. One method involves establishing the germ cell to cytoid cell ratio. A ratio of 13:1 is considered normal in a healthy young man. Approximately 12 cytoid cells per tubule is considered normal, and about half the germ cell elements should be in the spermatid stage. So this imaging in the upper right as a reference, we can see this also a stage of a sperm cells presence, including the spermatids in the luminal area. This feel like a cell, the number of actually abundant compared to the cytoid cells. And here actually overall reduction in numbers can be appreciated. We can roughly do the ratio thing, but usually in the practice we don't do it. We just kind of just give the impression. And the higher power we can tell maybe necessary, actually in this case necessary to note the presence of spermatid size, spermatids in this imaging, in this lumen and this tubule. There's cytoid cells. There's other stage of the sperm cells types, but the number actually reduced. So based on the findings, mark the hyperspermatogenesis with heterogeneous reduction was diagnosed. Again, I always mention adequate for evaluation. So based the bilateral showing the similar findings as well. So the hyperspermatogenesis is an equivalent decrease in the number of the spermatogonia and the primary spermatocytes. In this situation, the key we have to keep in mind to distinct it from maturation arrest. I mentioned several times to evaluate the presence of spermatids, which is if it present with the decrease in the number of the spermatogonia and the spermatocyte is hyperspermatogenesis. If lack of mature spermatid in the background of decrease in the number of spermatogenesis is the maturation rest. So reference list here, germ cell, Sertoli cell, ratio is 13 to 1, 12 Sertoli cells per tubule, and the presence of spermatid is half of the sperm cell element. The causes also varies, including hormone dysregulation, congenital germ cell deficiency, estrogen insensitivity, chemical agent exposure, exposed to heat or radiation, and even viral size. Sorry, viral cell. The third case, a 45-year-old male attempted to conceive with his 46-year-old wife. Semen analysis revealed zoospermia, similar to another cases. His male endocrine profile also within the normal range, including the similar hormones, including testosterone, LH, FSH, estradiol, sex hormone binding globulins, all in the normal range. Here, the lower part view showing them also multiple adequate tubules for evaluation. A few words regarding specimen handling and artifacts. Here, use this as example. Ideally, the surgeon should drop the tissue directly from the scissors into the fixative solution, thereby avoiding tissue compression. A fixative such as Bowen or acetic acid zinc formalin rather than a plain buffered formalin is recommended, because plain buffered formalin results in shrinking artifact and luminous sloughing of the cells, as we see here. However, in other areas, we can see a little bit of well-preserved tubules for evaluation. And there's also, we can see the lumen, usually go to the lumen first. The lumen, there's spermatocytes here, and also with other spermatogonia in the lamina, basal lamina, Sertoli cells, primary spermatocytes, and numerous spermatids in the lumen. So this actually showing the normal and the other normal spermatogenesis in this section as well. So by lateral biopsy showing this normal spermatogenesis, and then also no germ cell neoplasm in situ or germ cell tumor identified. This case, this patient is clinically suspicious for obstructive zoospermia. By definition, is absence of sperms in the ejaculate, despite the normal spermatogenesis. Actually, our biopsy confirmed that this patient has a normal spermatogenesis. The causes also is broad spectrum, including vasectomy, blockade due to trauma or infection, congenital conditions, including cystic fibrosis mutations, dysfunction in the process of ejaculation caused by neurological damage from surgery, diabetes, or spinal cord injury. So measurements can be done by surgical correction of the obstruction, especially for the vasectomy patient, or a retrieval of sperm from the male reproductive system, like the microsurgical sperm cell extraction. The couples actually proceeded with testicular sperm extraction and the egg donor followed by IVF. In summary, Testicular biopsy is generally reserved for men with azoospermia. Accurate pathologic diagnosis play a critical role in the diagnosis and treatment of men. A systemic approach to testicular biopsy interpretation include low power evaluation to assess proper tissue type, specimen adequacy assessments, and also initial impression of overall heterogeneity. At higher magnification, to evaluate the tubules, including hyalinization and cellularity, if all tubules are hyalinized and acellular, it's consistent with the seminiferal tubules hyalinization as we show in the beginning. If this finding is heterogeneous, scattered with an otherwise normal background, is most consistent with aging testes. Higher power view examination also provides an assessment of type and proportion of germ cell cells in the tubules. If all tubules showed absence of germ cells and only contain Sertoli cells, it's a Sertoli cell only syndrome. Overall decrease in germ cell quantity with or without Sertoli cell prominence, and also increased number of small diameter tubules seen in the uniform or heterogeneous type hyperspermatogenesis. If mature sperm absent in all the tubules within the biopsy, is a maturation arrest. If some tubules contain Sertoli cell only, but other tubules contain spermatis, it reflects hyperspermatogenesis mixed type. If lacking the findings aforementioned, it's a normal spermatogenesis. With that, thank you so much for your time. I would be happy to take any questions you might have. Thank you.